Good afternoon. Welcome to this week's edition of Grand Rounds at Murray Medical Center. Please be sure to fill out the program evaluation at the end of today's discussion. Today, I'm pleased to introduce my colleague and friend, Dr. Joe Merchant. Dr. Merchant is an oncologist here at Bliss Cancer Center and also serves in our certified breast cancer center here at Mary Greeley as well. When I was reviewing Joe's CV, I learned something new about him. I didn't realize that you were a Golden Domer. You went to Notre Dame for undergrad, so Joe is a Notre Dame alum. He did his medical training at the University of Iowa and fellowship training in hematology and oncology at University of Wisconsin. So today he's going to talk to us about some things regarding clinical findings in patients that may be on chemotherapy. So please join me in welcoming Dr. Merchant.
Can you all hear me now? Yep. Okay, great. Well, you know how you can tell in a room full of people who went to Notre Dame, don't you? They'll tell you. So anyway, so there's some truth to that. Well, the title for my talk came from a conversation I had with a patient not too long ago when I was beginning to explain the plan for their care. I was mentioning drug names and starting to talk about side effects, and he interrupted me and he said, "Now, is this chemotherapy or is this something else?" Because a lot of patients are now getting something else. And so that's really kind of what I intended to talk about today. And I set out my goals for my talk here. I wanted to use a case-based approach. I wanted to talk about real patients. And Dr. Hallberg had asked me to talk about chemotherapy. So there's so much to chemotherapy now that it was hard for me to narrow it down exactly what to talk about. So I didn't accomplish all of my goals, I'll just tell you at the outset, but we'll do our best. When I think most of us oncologists and oncology nurses think of chemotherapy, we're thinking about cytotoxic chemotherapy. That is traditional, old-fashioned chemotherapy. But there's a lot more to cancer therapy than that. We currently use right upstairs, probably right now today, immunotherapy, that is monoclonal antibodies therapy, checkpoint inhibitors, tyrosine kinase inhibitor therapy, antibody drug conjugates, and other hormonal therapy. So there's a whole lot of different types of medicine being used to treat cancer. I wanted to try to talk about ways in which chemotherapy, traditional chemotherapy, is being combined with some of these new treatments. And I also wanted to talk about side effects because we oncologists are increasingly dependent on our other colleagues for managing side effects because we're giving patients new problems that we're not used to taking care of, mostly autoimmune problems. Most of my talk is going to center on lung cancer, the main reason being that all these types of new therapy are being used in lung cancer, and lung cancer is one of the most common cancers that we see. In the course of this talk, probably 26 people will be diagnosed in this country with lung cancer. And lung cancer is a very deadly cancer, very common. So a lot of our patients upstairs are being cared for lung cancer. You can see that the number of deaths lung cancer causes exceeds the number of deaths from colon cancer, prostate cancer, and breast cancer combined in an average year. Lung cancer kills 2.5 times the number of men as prostate cancer and kills 1.5 times the number of women as breast cancer. And I think you can see that the amount of research dollars for lung cancer pales in comparison to breast cancer and prostate cancer. So there seems to be a little disconnect in terms of putting research dollars where the patients are suffering. And I think a lot of the reason for that has just been partly that we had such terrible results for so long with lung cancer patients that it was hard to gin up much enthusiasm. And also, there's, I think, a little bit of a bias that patients with perhaps, I mean, I'm just wondering, patients with lung cancer sort of who are smokers maybe brought it on themselves. So, there's a little bit of less willingness to try to devote money to that patient population. Well, here's my case. It turns out I intended to do many cases, but this is the only case. So this is a patient, actual patient, who's 84. She presented with bilateral hip pain and rib pain, and her doctor did an X-ray and then subsequently CAT scan, and this is her PET scan. You can see she has a mass in her left lung, and the mass was biopsied and is a poorly differentiated non-small cell lung cancer. She had no metastatic disease, and her performance status, although she had pain, was still performance status of 1. I'll talk about performance status because this is kind of important. This slide I'm putting in for Sarah. Where's Sarah Hykins? Oh, there you are. I have to put in something about staging, right, Sarah? So anyway, Sarah, so this is the 8th edition for lung cancer staging, the most recent edition. And this is kind of the bottom line in terms of staging patients. We have patients on the right who have metastatic disease. In the middle, mostly unresectable patients. We spend a lot of time at cancer conference talking about these patients and whether they should get chemo and radiation and surgery, or surgery followed by radiation and chemotherapy. And then there's the patients up on the left who are mostly resectable. And those are the patients who are the target of our lung cancer screening. If we can capture more patients in this group, those patients have a much higher rate of cure. They don't usually get chemotherapy, at least right up front. So I'm going to ignore those patients for the time being and focus mostly on patients with metastatic disease. This is some information just to help you understand when the powers that be change the staging for lung cancer. What they're trying to accomplish is a clear delineation of prognosis, and they're trying to stratify patients with different 5-year survival estimates. And they try to do this on an iterative basis. They try to get better and better over time. You can see the first slide here this is the T stage, that is the size of the tumor primarily. And patients with very small tumors, patients with very small tumors do very well on the top, and patients with bigger tumors do very poorly. And this is the nodal status, patients with node involvement. You can see that dramatically reduces the survival. The patients with N1 nodes, those are patients who have lymph nodes, lung cancer lymph nodes inside the lung, and that really dramatically reduces survival. N2 nodes and N3 nodes are lymph nodes that are in the center of the chest, the mediastinum, and those patients do very poorly. And then patients with metastatic disease in the 8th edition of the staging have been divided into M1A and M1B. And I included this mainly for my own sake because I wanted to see that we talk about patients who have contralateral tumor nodules. Contralateral tumor nodules are metastatic, but some of those patients are really curable still. And those are patients that I've had a few of those recently. And then this is just to even the most widely metastatic patients who have bone-only disease live longer than patients who have disease to the adrenals or liver, et cetera. All right, well, before I get farther, I want to talk a bit about performance status. Most of the studies I'm going to talk about only including patients who have a performance status of 0 or 1. And because of the cost of the drugs that we're going to talk about, I think it's important that we acknowledge at the outset what a performance status 0 or 1 patient is. Because in regular practice, like what I do, a lot of the patients really don't have a performance status of 0 or 1. So a patient who has a performance status of 0 or 1 is a patient who's has, if they're a 0, they have absolutely no symptoms from their cancer that are detectable. They effectively are a marathon runner who has lung cancer. And we don't have very many patients like that. Patients who have performance status 1 are a lot more common. Those are patients who are working, who are functioning in their average everyday life, who are out of bed and doing everything for themselves. Patients who are performance status of 2 are no longer able to work, generally speaking. Those are patients who are out of bed more than half the day, but aren't able to work. Performance status 3 patients are at bed rest for more than half the day, and performance status 4 patients are patients who are unable to get out of bed. And this is the slide on the right just demonstrates that lung cancer patients have a very high relative risk of having a poor performance status, and among the highest really of all of our cancer types. If you look at just performance status alone, disregarding the stage, you can see this kind of looks like your staging slides. Patients who have a good performance status live longer than patients who have a poor performance status. And you can read the slide for more information, but the drop-off is really pretty dramatic, even between performance status of 0 and a performance status of 1. And it holds for both men and women. So keep in mind that in the design of these trials, the patients they wanted were these performance status 0 and 1 patients. And the trials excluded those patients with the poorer performance status. I wanted also to put a pitch in for palliative care. This slide talks about, this is a very important study that was published in 2010 about the value of early palliative care for patients with lung cancer. And in this study, 150 patients with lung cancer were randomly assigned to get palliative care right at diagnosis along with chemotherapy, along with standard oncologic care, or to get standard oncologic care without early palliative care. And what they were able to show in this study is that there's a survival advantage to early palliative care. If this were a drug, they would sell it for $50,000 or $100,000 a year, and it would be FDA approved. So that's a big, for us, a big survival advantage, and the intervention was pretty simple. The patients met with palliative care physicians, palliative care certified physicians, and advanced practice nurses on a regular basis. And a lot of the details of this care related to attention to depression, anxiety, managing their social needs. A lot of patients who have lung cancer have a tremendous amount of social stress. So anyway, I just wanted to put this in because I think that's an important piece and something that we do have a palliative care program, but we don't have one that's functioning very well right now as an outpatient, on an outpatient basis. Okay, this is an old slide. This is talking about cytotoxic chemotherapy, the old stuff, the stuff that we still use every day. And it's an important slide because prior to the time that this study was done, we thought that chemotherapy for lung cancer, maybe should be given forever. Patients have such a terrible disease. We should just start it and we should keep giving it until the cancer gets worse. So this Dr. Sosinski did this study, and he said in his trial that he would give people 4 cycles of chemotherapy with 2 drugs, carboplatin and paclitaxel. And that's arm A, or patients would be randomized to arm B, where they get the drugs every 3 weeks until they progress. Well, what happened to these patients is they got really bad neuropathy. So this shows the number of cycles they received, and the percentage of patients who got debilitating, that is, highly significant and painful neuropathy. And it became clear that patients really had a pretty high rate of neuropathy the more they went into the treatment. Also, there was no advantage to survival. And I would just encourage you to remember this slide, because look at how many people are alive at 2 years. It's about 15%. So the 2-year survival was not different in either arm. We weren't helping people by continuing beyond 4 cycles, and so the standard of care as of 2002, when this was published, was stop at 4 cycles. It gives a little bit of data on the performance status, again, to show you that if you have a better performance status, you live longer. And this study did include some patients with poorer performance status, and but there was really no difference in terms of it didn't affect the trial results. I include this study again. This is straight chemotherapy. This study was published this year, last year. It's a study focused on only elderly patients, and a lot of our patients are elderly. To be in this trial, you had to be about 75 or older. It's an Italian study, and or over 70, I guess. The patients had to have metastatic disease, and this is the organization of the study. It combined 2 different common regimens that we use in elderly people: gemcitabine, and the details of the drug aren't important right now, or Alimta, which is both easy drugs for elderly people to take, either by themselves or with cisplatin, a very tough drug for cancer patients to take, especially the elderly. And the question is, can we get away with giving this drug to elderly patients, and would it improve their survival? These are the patients that are being seen in the study, and I would just call your attention to squamous and non-squamous. That's going to become an issue later. The performance status, all good performance status patients, mostly smokers. And the survival was poor. The cisplatin didn't help. And this is more reason why that we won't, or generally don't, use cisplatin in elderly patients with lung cancer. It doesn't help, and it did cause more toxicity. I think Dr. Hallberg wanted some stuff about side effects. So, truth in advertising: patients who get cisplatin don't feel good, they're nauseated, they vomit. That's 50% of patients. They have fatigue, and they have a lot of blood count problems. It's a difficult drug to take, and the quality of their life isn't good. To talk a little bit more moving forward in the care of lung cancer patients, I want to talk briefly about bevacizumab. This is a drug that's probably been mentioned many times at Grand Rounds, and it's used in a lot of areas other than lung cancer. It's used in treating macular degeneration now. It's an antibody against vascular endothelial growth factor ligand, and it affects the vascularity of tumors, and it's been shown to help in the treatment of lung cancer patients. In this important study, ECOG 4599, bevacizumab was added to the drugs Dr. Sosinski used in his study that I showed you from 2002. And it showed an improvement in overall response rate, tripling the response rate, and improving survival, overall survival by 2 months, 10 months to 12.3 months. Pemetrexed, the Alimta drug that I mentioned, that was used in the Italian study. This drug is an antifolate. It works by inhibiting these enzymes listed here: thymidylate synthase, dihydrofolate reductase, and it affects the production of purines, pyrimidines, affects cancers being able to replicate. And this study here is a Norwegian study that compared pemetrexed plus carboplatin and gemcitabine carboplatin, two commonly used regimens for lung cancer. In the bottom line, neither of them worked better in terms of overall survival, but pemetrexed was a lot less toxic. Patients had a lot fewer blood transfusions, a lot fewer admissions to the hospital, a lot fewer, I should say less nausea and vomiting. So pemetrexed became an attractive drug for us to use in the course of the 2005 to 2015 range, mainly because it is easy to take for patients, and patients have equivalent survival, less side effects. The next topic to talk about is the introduction of maintenance therapy using these two new drugs, pemetrexed and bevacizumab. I already showed you that using continuous cytotoxic chemotherapy with carboplatin and Taxol resulted in no improvement in survival with lung cancer and a worsening of quality of life. Pemetrexed and bevacizumab changed that, and it was changed mainly on the basis of these two trials. In the first trial, bevacizumab was given on a continuous basis to patients who did not worsen after 6 cycles of carboplatin, paclitaxel, and bevacizumab. And in the Paramount trial, pemetrexed was continued as a maintenance in a similar group of patients. And those patients who continued on the maintenance therapy did better. This is a study of ECOG 4599, and it showed that patients who got the bevacizumab, including the maintenance, had a two-month survival advantage, and the patients tolerated the bevacizumab well. This excluded patients who had squamous cell cancer because those patients had a high risk of life-threatening bleeding in some earlier studies. This study, the Paramount study, showed an advantage to pemetrexed given on a continuous basis. This study randomized patients who had completed 4 cycles of cisplatin and pemetrexed to either receive maintenance, pemetrexed, or nothing. And these are the side effects from the pemetrexed. You can see, as opposed to the cisplatin, which had side effects in the 50%, 60% range, patients feel bad. Pemetrexed patients' side effects are in the 4 to 5% range. These are patients who can take pemetrexed, and I've had patients remain on maintenance pemetrexed for 2.5, 3 years, every three weeks. It's a drug that patients can really survive and live with. So patients have, because of the benefit of both bevacizumab individually and pemetrexed individually, studies were done to compare the patients to compare the benefit of one versus the other, and then also to look at the combination. And would that be even better? So this study, ECOG 5508, unfortunately showed that there was no benefit to combining pemetrexed and bevacizumab maintenance, and there was more side effects. If you look at the grade 3 side effects, pemetrexed was 32% of patients had grade 3 side effects, but the combination 43%, and no survival advantage between the groups. So we now we're left with this combination, the general idea that pemetrexed alone is usually the standard of care in patients who are eligible for maintenance. That brings us to checkpoint inhibitor therapy. Many of you probably see advertisements on television for the various checkpoint inhibitors that are being given now, including Opdivo, Keytruda, and others. And so I want to talk some about checkpoint inhibitor therapy. The first big study I want to highlight is the Keynote 24 study. All the pembrolizumab being the drug in this study, all the pembrolizumab studies are denoted as keynote studies. All the Opdivo studies are denoted as checkmate studies. So us physicians try to keep up with the latest keynote study or the latest checkmate study. In this study, it's an important study, kind of heretical at the time, was the idea that you could have patients who have stage 4 advanced lung cancer and not give them chemotherapy. It was pretty amazing. You gave them, in this study, you randomly assigned patients with stage 4 lung cancer to receive pembrolizumab, a monoclonal antibody, and I'll show you how it works, but pembrolizumab against chemotherapy, investigator's choice, any of the drugs you really want to use. And the patients had to have, in this study, they had to have a particular feature of their cancer. They had to have more than 50% of the cancer cells had to stain positive for a molecule called PD-1. And I told Dr. Weidert I was going to include some slides, so I stole these off the internet. But these are slides of PD-1 testing showing kind of what Dr. Weidert has to try to decipher on our lung cancer patients pretty routinely now. And that is this a patient who has a PD-1 level of greater than 50%? Because if they do, if they're in this bottom right area on their, if that's what their cancer shows, they qualify for Keynote 24 treatment. So I wanted to include a little bit about testing for PD-1 because honestly, this is confusing. You have on the top here of this study, or in this table, you have 1, 2, 3, 4, 5 different drugs that are approved and in everyday use for our patients. They are all monoclonal antibodies to PD-1. They're all checkpoint inhibitors. And you can see in their FDA approval, this is the antibody that is used in getting their approval. And they're different. This one, for example, looks at both the tumor cell and the immune cells around the tumor. These others, as I understand it, look only at the tumor cell. This is a study that looked at how often pathologists agree with one another when they look at these studies. And it turns out there's pretty good inter-observer agreement, more than 80% at least, but it's not 100%. And the other thing that's important to keep in mind from my point of view is that if you biopsy the same tumor and do this test on the same tumor in the liver, it may look different than in the lung. And if you do this test on a fine needle aspirate, the test may be negative, but if you then get a bigger biopsy, the test may be positive. In other words, within a tumor, the test can vary from slide to slide quite a bit. So it's important to keep in mind when we say that a patient is cold, immunologically cold, we're saying their tumor is PD-1 negative, PD-1 antibody negative. But it's important to keep in mind that there are vagaries of the testing. You have to wonder what antibody was used. Is it the correct antibody? Do we need to get more tissue and do a repeat biopsy? Do we need to biopsy a different part of the body? And all of that. So in any case, back to Keynote 24, the patients in this study were performance status 0 or 1. It's important to point that out. I've talked about why that's important because you'll see at the end of the slide how much these drugs cost. The patients were mostly in their 60s. There was mostly the patients had adenocarcinoma. Some had squamous cell cancer. Some had brain metastases. And this study showed a pretty dramatic improvement in overall survival, progression-free survival in patients who received the pembrolizumab compared to the chemotherapy. You definitely, if you were a patient, you wanted to be on the blue line here, not on the red line. And the benefit was really in every subgroup. studied. It was benefit in men and women, older, younger, squamous, non-squamous, smokers, non-smokers, prior smokers. Everybody benefited. And although this is too small probably to comment on, I think you can appreciate that if you look, side effects, chemotherapy and pembrolizumab. A lot of patients had zero side effects. Our patients who get this drug feel really good. They feel great for the most part. I'm going to talk about some of the bad side effects we see, but I'm still shake myself sometimes because I can't believe this little patient who's in front of me, including the patient that I'm talking about, my 84-year-old, is just raking the yard, cleaning the gutters, doing whatever they want, and they're just sailing through treatment. So patients had a high level of response in the pembrolizumab patients. Patients responded quickly. Patients who get these drugs, you know whether they're working pretty fast, and they live a long time if they respond. The overall survival is, you can see patients in this group here's your 21 months, more than 60% of people are still alive. That's so different from what we're used to seeing in those previous studies that I went through with our latest, greatest, best drug, bevacizumab, which we thought was pretty special at the time. Keynote 189 is another study, and it was done because they realized, the folks who make pembrolizumab realized that only about 30% of patients 28%, 25% will have a tumor proportion score of more than 50%. So they're missing out on 70% of patients or more with lung cancer. So in this study, they included everybody else, patients who had a lower tumor proportion score. And in this study, they gave pembrolizumab plus chemotherapy for 4 cycles. And then patients were maintained on chemotherapy, pemetrexed, the Alimta drug that I told you is easier to tolerate, plus pembrolizumab, or the pemetrexed by itself. So chemo plus immunotherapy, or chemo plus checkpoint inhibitor therapy, or chemotherapy alone. And in this patient population, again, the patients who received the chemo plus the pembrolizumab did astonishingly well. Patients live a long time. They seem to have some patients who go into complete remissions. It seems to work in every subgroup, and it's way better than chemo by itself. Again, the patients tend to do very well with the side effect profile. The combination with pembrolizumab did not result in a dramatic change in the combination, in the side effects of chemotherapy alone. It didn't, in other words, it didn't make chemotherapy a lot more toxic than it already was. I want to talk briefly about the Checkmate 227 trial. This trial was just published September 28th. And in this trial, you can see that patients received a different combination of immunotherapy drugs, nivolumab, which is a competitor to pembrolizumab, plus ipilimumab. Ipilimumab targets a different molecule in the checkpoints that control T cells. Nivolumab and ipilimumab are made by the same pharmaceutical company. And in this study, patients had stage 4 lung cancer, and they were randomized to different treatment programs depending on their PD-1 level in their tumor. If they had a 1% or more, you can see in red what their randomization was. If they had a less than 1%, a different randomization. Basically, the patients in the less than 1% were randomized to get chemo plus nivolumab. But the important point here is that some patients were treated with 2 checkpoint inhibitors. And the patients who got 2 checkpoint inhibitors basically at the same time did way better than people who, or significantly better, I should say, than people who got chemotherapy This is demonstrated in this overall survival slide that looks at patients who have a PD-1 level of 1% or more. Patients had a 2-year survival rate with Nivo and Ipi of almost 50% compared to 11% for chemotherapy alone. So patients are not getting chemotherapy, and they're 5 times as many are living 2 years. The risk of death was lower across subgroups, so patients did well with this combination for the most part, and whether you had a low tumor proportion score of less than 1% or above 1%, you had an advantage for taking this combination. This talks about some of the serious adverse events, and I'm going to shift gears to talk about that. Adding ipilimumab definitely increases the intensity of the side effects, the autoimmune effects. You can see that skin reactions occur in more than a third. Patients develop endocrinopathies. That is the autoimmune effects on the endocrine system. And treatment death is more common. This is not an easy regimen to give, and it's a regimen that I've given and definitely seen people develop such severe immune reactions that they are hospitalized. This is one last study that I think is important to highlight. This is the Empower study using a different monoclonal antibody, atezolizumab. All the atezolizumab trials are Empower, Impassion, et cetera. This group was given the old standard of care, which is carboplatin, paclitaxel, and bevacizumab, or what they proposed as the new standard of care. And I went through the ECOG 4599, ECOG 5508. This study, they gave carboplatin, paclitaxel, I forgot the paclitaxel, carboplatin, paclitaxel, bevacizumab, the monoclonal antibody to VEGF, and atezolizumab, a monoclonal antibody to the PD-1. And they were able to show that the 4-drug regimen has an advantage in terms of progression-free survival compared to the 3-drug regimen. So patients who have, they also had an overall survival advantage. And if you, again, look at the two-year rates, a lot more people are living 2 years. Part of the reason I want to show this is because you are also caring for these patients of ours. And you're seeing them back, they're living a long time, and they're coming to you now with new problems related to their treatment, and we need your help. So these are some of the side effects that I'll just, in the interest of time, go through quickly. But the bottom line is adding a checkpoint inhibitor to prior standard 3-drug chemotherapy did not significantly increase the side effects or ruin quality of life. And we do have patients getting this 4-drug regimen now upstairs. So autoimmune toxicity, endocrinopathies, I saw Dr. Crano here earlier. There he is. He's had to handle several flaming disasters for us, I think, already. So, but usually they're not too bad. Hyperthyroidism is the one that kind of scares me. One thing we see with these patients is they develop fairly soon, some develop a really significant thyroiditis, an autoimmune thyroiditis, and they develop hyperthyroidism, very high T4, T3 levels, very low TSH. And it's been reported that patients can have life-threatening thyroid storm. I don't think, seen that. If I did, I didn't recognize it at the time. But patients can become very hyperthyroid and require immediate care or help from an endocrinologist. More commonly, we see patients just slide into hypothyroidism and develop significant elevation in their TSH and reduction in thyroid hormone. This is a lot more common if we use if we use the checkpoint inhibitor PD-1 drugs plus ipilimumab, if we just use the checkpoint inhibitor pembrolizumab, atezolizumab alone, the anti-PD-1 drugs, we don't see quite as much hyper or hypothyroidism. Hypophysitis is something that may show up in the emergency room and that you may see in your office. You get a patient who has a headache. A lot of times it's described by our patients as being the worst headache they've ever had. And you can see that they just had a brain MRI 6 weeks ago, and there's no metastatic disease. Those are patients who should be suspected of having hypophysitis. And I certainly have had patients who have had dramatic responses to the checkpoint inhibitors, but at the end of their treatment have no ability to make testosterone, thyroid hormone, adrenaline, any useful hormones, and are completely dependent on replacement hormones. Primary adrenal insufficiency can occur in isolation, and we have had patients develop type 1 diabetes, patients who have previously no dependence on insulin, and they develop an autoimmune effect that is pancreatitis, autoimmune pancreatitis, followed by insulin-dependent type 1 diabetes. Pretty high price to pay for cancer therapy, but you'll see patients who develop these autoimmune reactions are more likely to respond and go into remission with their cancer. So this is a slide of dermatologic effects. You can see that it's a pretty severe rash. This patient is very itchy. It's much more common to have a rash like this if you use combination chemotherapy PD-1 drugs with ipilimumab, CTLA-4 drugs, that is 2 different checkpoint inhibitors at the same time. A lot of patients are left with patchy vitiligo. I had a patient just yesterday I saw in Marshalltown. He had a terrible rash on his back when he was on treatment, but now he just has white splotches all over his back. Doesn't bother him, he can't see it, but he still itches about 4 years later after this treatment. His cancer's in remission, metastatic melanoma. Cardiac toxicity, this is a case that I took from PubMed that shows some of the effects that you can see. Patients can show up with typical chest pain, congestive heart failure, heart block, pericardial effusions, and be extremely, extremely ill. This patient in this study, despite getting high-dose steroids, developed heart block and progressed to cardiac arrest and died. You can see that when they did his autopsy, he had T cells infiltrating his myocardium. So his treatment for lung cancer caused his T cells to attack his heart. This is a case of autoimmune pericardial effusion with biopsy of the pericardium showing T cells in the pericardium. And, so patients, I want to bring these up because these are patients who are going to come to the emergency room or come to your office not knowing what's wrong with them, not thinking that it has anything to do with their checkpoint inhibitor therapy. So it's important to keep in mind and say exactly what drugs did Dr. Merchant give you? What did he do to you? And could it be related to your new diabetes? Could it be related to your itchy rash, your headache, the fact that you are diabetic all of a sudden? These things are all connected. So these are slides that I just include autoimmune to remind myself to mention them. Autoimmune pneumonitis, Dr. Fulton's here, and I don't know if we have several patients who come in now with quote unquote pneumonia after lung cancer therapy. Do they have pneumonia or do they have autoimmune pneumonitis? The symptoms are similar. They can have fever, chest pain, low O2 sats, dyspnea, acute respiratory distress. So how do we take care of them? Do we give them all antibiotics and wait? Do we early give steroids? So it's a difficult question. And you can see there's some advice, there's some standards that have been made in terms of how to manage these patients, up to and including giving chemotherapy to turn off the autoimmune cascade to try to save these patients. Patients can develop autoimmune hepatitis, including fulminant hepatitis and causing death. You can see that patients can develop coagulopathy, encephalopathy, elevated bilirubin, and you try to use steroids, you try to use mycophenolate, but not everybody survives. Thankfully, this is very, very rare. Patients have diarrhea. Some patients develop fulminant Crohn's or fulminant ulcerative colitis. And these patients, I have had patients who've received the combination of the two checkpoint inhibitors who have had to be admitted to the hospital on TPN and receive infliximab. This is just to show that oncologists are now anti-rheumatologists. We're the opposite of rheumatologists because we're causing all of these problems that our patients are now getting. And these problems in our patients who survive cancer, they last the rest of their lives usually. This is a study looking at urothelial cancer because we're using these drugs a lot now in bladder cancer. And it shows that if you have an immune adverse event, an IMAE, you have a better overall survival than if you don't. So it's good if you get a rash. It's good if you get rheumatoid arthritis or ulcerative colitis or something, because that means your T cells are really turned on, and you're in a group that's more likely to respond. Patients who develop these autoimmune drugs or autoimmune effects live longer, have higher response rates. A lot of patients have to be referred to rheumatologists now because or endocrinology, cardiology because of these effects. We have to keep our patients' expectations in line. A lot of patients come to us thinking, you're going to give me these miracle drugs and they're going to work. But in all honesty, as good as these statistics look for lung cancer, it's the minority of patients who get these big win effects. And it's also true that in patients getting combined immune checkpoint inhibitors, they have a lot of side effects. Some patients have accelerated tumor growth if you have these checkpoint inhibitors. I wanted to mention for Dr. Fulton also that there's an increasing body of evidence that the bowel microbiome has a significant influence on your chance of responding to checkpoint inhibitors. They've shown that patients who have recently received or had prior exposure to antibiotics have a much lower risk or much lower chance of benefiting from checkpoint inhibitor therapy. And it's felt that one way to enhance the chance of patients responding is to give people fecal transplants with beneficial bacteria prior to treating their cancer, or perhaps giving them what are called prebiotics, so giving them specific types of bacteria in their gut, hoping that the bacteria will modulate the immune system to make it more likely that the patient will respond. But it's just one more reason why we kind of don't want our patients to get antibiotics unnecessarily. This is an example of a patient who had rapid growth on checkpoint inhibitor therapy. And some patients, we give them the drug, and you can see that prior to getting the drug, their cancer was growing, but slowly we give them the drug and it explodes. And this is a pattern that we have to prepare ourselves for, as well as our patients. This rare but unusual, dramatic progression. And it may be that those are patients perhaps who have a particular fecal microbiome that sets them up for an adverse outcome. I can see my time is getting short, but I just want to mention that we used to think, and maybe we should still be careful, but we used to think patients with autoimmune disease couldn't get these drugs. It was unsafe. But it turns out that when you study it, actually people don't do all that badly. And so patients may receive, some patients at least, may receive these checkpoint inhibitors even if they have an autoimmune disease. Usually we have to talk with their rheumatologist first and just go forward if they, with full knowledge and close follow-up of their rheumatologist. There's probably about a 30% chance that they will have a flare of their autoimmune disease, and that flare can sometimes be managed with low-dose steroids. Patients who have baseline dialysis or who are on congestive heart failure or have cirrhosis can get these drugs. Patients who are at extremes of age can get these drugs and have similar benefit as younger patients. Patients who have poor performance status, this is an issue because they weren't in the major studies, but there are people who have done studies of patients with poor performance status and have shown similar or reasonable benefit. And of course, these patients have a 0% chance of responding to traditional chemotherapy. So if you are a person with a poor performance status, bladder cancer, you have a 25% chance of responding to these drugs. Given as single agents, you may decide to choose that over nothing or over hospice. Patients who have brain metastases can be given these drugs and respond to them. They don't seem to penetrate the blood-brain barrier very well, but perhaps used in combination with radiation, they represent a reasonable alternative for patients who have lung cancer or melanoma. My patient, I didn't get another slide of her scan, but she has had a complete remission, is still working very well in her yard, doing everything she wants to do. She's continuing on therapy. I'm not going to go into much more about lung cancer, but I just wanted to include this slide and one more. These are patients who have adenocarcinoma. And it talks, I think, the patients I've been talking about who are getting checkpoint inhibitors and chemotherapy are these patients who don't have a known mutation and these patients with KRAS mutation. Nowadays, everybody gets a molecular characterization of their cancer. So we know whether you have a MET amplification or EGFR mutation or ALK or BRAF. And that happens because we have drugs specific to all of those mutations. The driver mutations I haven't even talked about today, really. Those patients are handled quite separately and differently. Those patients generally don't get the checkpoint inhibitors because their mutations predict such a high level of responsiveness that they get those drugs first. This is, I think, my last slide, and this just is one slide talking about how oncologists, these are the NCCN guidelines for lung cancer, and it kind of gives you a flavor of the complexity now. We used to just give chemo or no chemo, but now we have to do molecular testing, including PD-1 testing. We have drugs, we have different pathways for ALK-positive disease, ROS, BRAF, et cetera. And each of these areas are almost like different cancers. They're handled differently, and they have different evidence bases that support the use of those drugs. So I'll stop there and just thank you for coming. I really appreciate all of you being here. Hope you learned something good about chemotherapy. Thank you. Are there any questions? Yeah. Oh, wait, one more. I wanted to show you the cost. Most important. So look at the cost. The cost of these drugs is really substantial, and consider the combinations. Oops. Ipilimumab cost per cycle, per 6-week cycle, $56,000, $73,000. So these drugs are really, really high. And we're giving them to patients who have common cancers. Lung cancer is really common. So anyway.
Joe, could you just quickly tell us what the molecular characterization of the cancers would entail? Is it a simple blood test that you send off, and is it for each different cancer? I just don't really know much about that.
Sure. Yeah, so I think the main thing that we do is we send tissue that is fixed tissue from a biopsy sample to a reference lab. Usually here we're sending it to a lab called Foundation One. So if you watch TV, you'll see ads now for Foundation One testing. And that's called next generation sequencing. And it's a process by which the Foundation One lab tests the cancer for pretty much hundreds of mutations that are associated with cancer, and also specifically mutations that predict responsiveness to certain drugs. And Foundation One sends us a report, usually about 20 pages, that includes all the mutations they found and all the clinical trials that those mutations will make the patient eligible for. And also if there are any FDA-approved drugs that are associated with that patient's mutations. But there are also what are called liquid biopsies, and that would be a talk of its own, where we send patients' blood at diagnosis. A lab that we send that to is called Guardant, and those patients are patients who are quote unquote shedding patients that we can find DNA mutations in the blood. A lot of lung cancer patients are shedders, so we can find their mutations without a biopsy. And that becomes important because some of these patients' biopsies change over time. Their liquid biopsies show that they're developing resistance, and we can see that on blood tests by checking the mutations serially. But that adds a whole other layer of cost to patient care because Foundation One testing is $3,000 to $5,000, and if you're doing it multiply, it becomes pretty high. But yeah, it's important. Go ahead.
How fast do these immune complications occur after chemo? I presume it's variable, or is it something you'd see in 2 months or 2 years?
That's a good question. I should have included some slides on that. They occur pretty fast. A lot of times immune effects occur before the patient responds. So the first one we usually see is a rash, usually around 3 weeks. And then we see diarrhea around 5 weeks or 6 weeks. And then after that, we can see some of the other side effects, but rash and diarrhea are the earliest. And a lot of times they occur, we don't do scans. Usually patients are responding at about 2 months if they're going to respond, but they've already been living with diarrhea and rash before that. So, any other questions? Okay. Thanks again for coming.